Good evening. Welcome to the Blavatnik School of Government for the first in what we hope will become a regular series of global health systems expert talks here at Oxford University. My name is Martin Williams. I'm an associate professor in public management here at the Blavatnik School and research fellow at Green Templeton College. And it's my pleasure to be here moderating tonight. Our first speaker is Diana Pinto, who's a health lead specialist at the Inter-American Development Bank. Diana also has experience in academia on the research side, with civil society and NGOs, as well as in government. So she's incredibly well placed, I think, to give us a really interesting perspective on thinking about health from a systems perspective. So the format for tonight, we also have two other speakers. Each speaker will speak for about 15 minutes, and then we'll do 5 minutes of Q&A before moving on to the next speaker. So with that, let me hand it over to Diana, and thank you for being here.
Well, first of all, thanks for organizing this. It's very exciting to be at this iconic place of knowledge. And before I start, I want to explain a bit of how I've thought about this presentation. I'm going to tell you a story, basically, so don't expect numbers, evidence. I have all the numbers for whoever is interested in that, but just bear with me with a storytelling, which I think is what I can really add value to from my personal experience. So I am going to basically try to explain through the view of Colombia's healthcare reform what the actual challenges in Latin America are. So it's not trying to generalize, but I think as you listen, you will probably resonate in your mind with things that you've been reading or listening to, such as universal health coverage and what needs to be done about this. And so just keep that in mind as you listen to the story. So again, what is my story about? It illustrates Latin American health system challenges through Colombia's design and implementation of health system reform to reach universal health coverage. And the other thing is that I will focus just on the financing function, which involves revenue collection, pooling, and purchasing of services. There are many other things that I could talk about with this reform, but I'm just only going to focus on this specific function of health systems to make a point. So this is one of the stories' location. I hope you're able to go there someday. And the first part is we're starting from a very well-known situation. The challenges in 1992 basically were a country with a three-tiered health system. That means 3 separate subsystems, a national health system that covered about 50% of the population, a mandated health insurance covering around 20%, private insurance for 11% of the population, plus a large parallel private market serving unmet demand and quality. I think nowadays you will find a very similar situation in most countries in Latin America, except the Caribbean, and probably Cuba and Costa Rica would be the exceptions as to this situation. Now the challenges, basically what you hear, this is like stylized facts. Demographic and epidemiological transition, public sector quality and efficiency issues. Cost of care was the major barrier for 55% of the population to reach health services, and large inequities in health outcomes and access to services between urban, rural, and poor and rich. I think that it's very easy to envision a similar situation in many countries nowadays. So what happened? I call this the health system's Big Bang reform. And this was Law 100 of 1993. This reform addressed not just the issues of financing that I'm going to mention to you, but it had a system-wide approach. So there were reforms to human resources, quality of care, governance, etc. So essentially, in a nutshell, What the reform did was that it established universal health insurance coverage through two separate schemes. One with the contributory regime, whose target population was formal sector workers, with a very, very comprehensive health benefits package. Then it separated the benefits for the population that was less, with less ability to pay, the poorest population eligible for subsidies, into the subsidized regime. And here, the package that was covered was much less than that for the contributory population. But nevertheless, it still covered a substantial amount. You can see that preventive and low complexity ambulatory care, as well as even high-cost medications were covered by this package. And in terms of out-of-pocket expenditures, no cost sharing for emergency care and preventive services or services of public health interest, and sliding scale fees or co-payments for other types of services. So these were the financing choices that the country took at that moment for whom and what to cover. With respect to revenue collection, for the contributive regime, the reform established, raised the payroll contribution at that time. And for the subsidized regime, several sources were pooled. First, there was a reallocation of existing funds through increment of existing transfers for health from national and local revenues. Also, a transformation of the supply subsidies that were geared towards hospital was envisioned. And so instead of sending money to hospitals, demand-side subsidies, money followed the patient scheme was established. Plus, additional funding was sought through a 1% solidarity point from the contributory funds. Plus, it was expected that there would be revenues from taxes of oil exploitation to serve the subsidized regime as well. Now, this graph is just to, I fortunately don't need to explain it, but basically what happened was that all the different sources that I mentioned were pooled into a single fund that afterwards distributed the monies for the contributive and subsidized regime. But a very important pooling function decision was taken. Now, with respect to financing choices and purchasing of services, what was established was a managed competition scheme in which differential per capita premiums, one for the subsidized regime, the other for the contributory regime, were paid to HMO-type insurance companies, which were to deliver the mandatory package, or it was called the POS, Plan Obligatorio de Salud, through contracts with public and or private service providers networks. So this was like a two-tiered managed competition scheme, which basically transformed the country into working from historical budgeting to some sort of strategic purchasing strategy. So what were the great expectations? Convergence of the two regimes was envisioned to happen in 2001 as funds became available. And it was expected that the funding would become available based on a very rosy economic growth and employment projection. But the road really turned out to be with quite a few unexpected turns and bumps. So in terms of revenue collection, macroeconomics got in the way. I am showing you the expectation from 1992 to what actually happened. So in 1992, the expected annual economic growth was 5% and an increase in average income of 1.8%. And a lot of increases in formal sector and informal sector workers were also expected. The reality was that in 2001, between 1996 and 2001, the average GDP growth was actually 1%, hitting negative values in 1999, and the unemployment rate soared to 20%. Now, to add to that, with respect to revenue collection, there was a large effect of evasion and elusion on contributive regime revenues, and the transformation of supply subsidies did not happen as envisioned either. There was quite a bit of political opposition because this meant taking away money from public providers, as well as there were some design issues with the benefits package, which to the extent that it did not cover a lot of things in secondary care, it really justified the existence of public provision for what those things that the package didn't cover were. So the resulting budget constraints from this was that you can see there the projected resources and the actual expenditures. So in 1994, this was what would be expected of the growth of resources from the solidarity point that I mentioned and from national resources for the subsidized regime. It was expected to reach this in 2000. There was no data in 1994, and the actual expenditures were these. Now, to add to these different complications, well, enforcing a benefits package did not turn out to be as easy as initially thought. And here, the right to health and constitutional court rulings start playing a key role. And I think this is also a situation that you will find in most Latin America. So in 2008, the Constitutional Court actually thought that there was a violation with having two separate regimes, and it ordered the Ministry of Health to unify the benefits for both regimes and equalize those by 100% by 2010. The government started working on this, and in 2015, a statutory law declared that the state had to guarantee everything and that having a benefits package was also unconstitutional. So the benefits package was eliminated. And finally, what happened, what really took place was kind of an unmanaged competition, because the rules of the game for managed competition to happen were really underdeveloped or not implemented, and weak incentives for the HMOs to act as strategic purchasers were there. So what were the gains from the journey? I think it's important especially to emphasize what was gained in the first years of the first 10 years. So you can see that in terms of urban and rural insurance, basically from 1993 to 2003, the gaps were closed in a very important way. And here you can see the growth of insurance between 1993 and 2003 with respect to urban contributory regime and rural and urban subsidized regime and rural. And you see that the great achievements were gained for the poorest and rural populations. Colombia passed from spending 1.6% of its GDP to more than 6.2%, to 7.8% of the GDP in health. Out-of-pocket spending by households was reduced by 78%, reaching the lowest level of the region. And by 2003, more than 84% of total spending was public, 66% of it dedicated to subsidized regime insurance. And in terms of health and equity, I just mentioned here is the real evidence, but summarizing this, basically what you see are great achievements in terms of health outcomes for the poorest and rural populations. So to end the story, now more than fine-tuning is required. In terms of universal health coverage, we're practically there. What this graph shows you is basically that we have reached 90% of the population, and I say we because I'm Colombian, so I feel very close to this. But still, a lot of challenges remain in terms of financing. It's a fact, and this is a worldwide situation, that healthcare spending will continue to grow from demographic factors, technology, etc. And in Colombia in particular, because now we have eliminated any possibility of controlling spending with this blow to the benefits package from the Constitutional Court ruling. So what are the decisions that need to be made? Well, the country really does have to define how much does it want and need to spend. This is, at the end, a social decision. With no limits, there are also questions about, do we need more resources, or are we going to focus on efficiency? There is quite a bit of evidence that a lot of improvement could be done in terms of efficiency. And the other issue is, how is priority setting going to take place? Some social agreements will have to be reached with the population, with providers, with practitioners. Is this really a feasible situation of giving benefits of all kinds to everybody? And finally, the managed competition model will need to be revisited. With this, I end my talk, and I have to confess that I have a secret agenda, that if I achieve it, I will be very happy, which is that I need to remind you that this is Colombia. It's not Colombia. And if I achieve everybody really getting into this, their mind, I think I've done much. Thank you very much.
Thank you, Diana, for that really interesting peek into healthcare reform in Colombia. Right? Colombia. So we have time probably for about 3 questions. I'd like to take all 3 together, so please keep them concise and 1 question per person, please. If you can raise your hand so our microphone people can find you. We have 1, 2, 3.
Hi, Diana. Thank you so much for your talk. You were talking about the country's going to have to decide about spending next, how much you want to spend and resources and so forth, and getting those social agreements. I was wondering if you could expand on how you would get those agreements. What's the process of that?
Okay. Second question.
Hello, thank you. That was incredibly interesting. My question is actually on getting to 100%. I was wondering how much of your problem that remains is actually on incentivizing doctors to remain in particularly rural areas, particularly those that the people are very poor and have problems affording transport to larger metropolises that might have better healthcare options.
Okay. And our third question in the back there.
Oh, thank you. And thank you for your presentation. I'm Nyalianga, and I come from a third world country, Zambia, where there are very few hospitals. So I was wondering if, for us to get to such a level, should we start with the implementation of hospitals across the country, or with the improvement of our current hospitals, which are currently not in a good state?
I'm sorry, can you repeat your question? I didn't quite get it.
Because we have, as government, we have a few hospitals within the country that are owned by the government. But I feel like for us to be able to implement the program of health insurance, we might need to have several government hospitals across the country. Correct me if I'm wrong. So my question is, how do we go about it, or how would you recommend that we go about it? Should we start by implementing the procedure where we improve our current hospitals, or should we start by including more hospitals across the country? Was that clear?
In terms of provision?
Yes.
Yeah. Great, thank you. So Diana, you have a question about getting social agreement on healthcare spending, a question about how do we get to 100%, and is particularly with doctors in rural areas, and a question about if you're starting from a low base, should you focus more on coverage or on quality and provision within that existing system? And you have about 2 minutes to address those three small questions.
Well, I'll be the next Nobel Prize of Public Health if there is one.
The first.
Okay, with respect to social agreement, I think you have placed like the thorniest question that health systems are going to face. Because again, I emphasize that this is not a situation just of Colombia. And my point with this particular topic is that, well, the buzz for universal health insurance talks about formulas for designing benefits packages and, you know, restricting your, well, setting limits. And setting limits is going to be a huge challenge. How to do it? I think we have a lot to learn from the UK in the sense of, well, I guess NICE's work, which is not so nice, as I understand, has a lot of interesting lessons about how to say no. I think we have to place it in a cultural context, which is also different, but I think that is one perspective that you could assume. The other is really working with civil society to have it. These are all, you know, my personal ideas, but I do think that a big work needs to be done both with practitioners, with civil societies, as well as with the judicial system in terms of thinking together about what setting limits is about and where the collective benefit lies. Actually, there's a very interesting initiative led by the World Bank, which is called Salud Derecho, in which they have been doing a very important job, and Fari, you're the expert on this, of getting judges to use evidence and understand what evidence-based medicine is and incorporate it into their decisions. So these are some options for what you asked me. I don't have the answer, but that's the way that I see where we could move forward in this particular topic. The second question?
Getting to 100% and
Okay.
doctors in rural areas.
You know, I honestly don't think getting to 100% is a point. There will always be people out of the system. What you asked is very important. What you want is that those people are not the most vulnerable population. And in the case of Colombia, that percentage that is missing, what studies have shown is that it's usually, well, first, people who move from one system to the other and don't get registered appropriately. The other is people with capacity to pay that also are not registered in the system and who don't really, well, it's very hard to track them. So I don't think that necessarily getting to the 100% should be the point, but rather in making sure that in that possible 10% that doesn't come out in the figures, you don't have vulnerable populations.
And the third question on coverage versus quality within the existing system.
Okay, one of the tensions that I find with the universal health coverage recommendations is that they really leave governments with no guidance as to what should they give weight to. You know, everything is kind of set on the same order of importance: financing, human resources, quality, etc. From the practical viewpoint, what I've seen that governments are doing, at least in Latin America, it's that they're really starting first on defining a focus, an area, a population to focus on, get the money first for coverage, and then start working on different issues according, well, this is very context specific, to the feasibility of doing certain types of reforms. So I don't think there's like a formula for this. It's quite context specific. But I guess that the message for you is to keep it rather simple without not having a plan for the rest of things that need to be in place to happen. But not try to do the big bang, but do follow a more orderly implementation north.
Great. Diana, thank you very much. Please join me in thanking Diana. And also welcoming to the stage our next speaker, Fadi El-Jardali, is a professor of health systems and policy at the American University in Beirut in Lebanon, and is taking us over to the other side of the globe now to talk about health reform in the Eastern Mediterranean. Over to you.
Thank you, Martin. It's good afternoon. It's my pleasure to be with you today, and also to visit Oxford University and meet with bright students, and also meet with faculty. So I'm going to be talking a little bit about our experience of actually trying to influence policy and practice using evidence. And so I'm going to reflect a little bit over the last few years of how we actually start to think about this important topic, and how we start actually more of a making impact when it comes to informing and shaping policies. So I'm going to be talking about, how we actually figured out that there is really a major gap when it comes to informing policies and making good decisions when it comes to public health and health systems. And then we'll talk about how we actually created institutions to start actually providing and cater to the needs of policymakers and stakeholders, and provide them with the timely response to their request for evidence. I'll talk a little bit about impact-oriented approach. I have some stories to share with you, and we're still learning. So there have been successes. There have been things that we thought we have to do it differently. There's a lot of work that we're doing also to evaluate our approach, but this is something actually it's good to have some reflection about. Now we have conducted research on research, and we have actually realized that in fact in the Middle East and North Africa region, in fact, there is a lot of challenges when it comes to health systems and policy. However, there's a really poor production and poor alignment between the priorities versus the production of research. So we're producing research here, while the policymakers requiring evidence on something else. So the question is really how to come closer so we can speak the same language and provide policy-relevant type of evidence. So we've looked at this, we've published work. I'm not going to go into the detail, but we've realized, in fact, many of the articles that we produce in the region that, in fact, do not reflect priorities. We've looked also at the poor alignment when it comes to systematic reviews, and we have found only 3 were out of more than 1,000 systematic reviews were produced by at least one author based in the East Mediterranean region. So you can see there has been really also poor capacities in terms of knowledge production, of doing research on primary studies, as well as doing systematic reviews. We've also surveyed, we've done a study in 11 countries, and we surveyed more than 250 senior policymakers, including ministers of health, parliamentarians, politicians, director generals, and we found that, in fact, more than 65% of them indicated that systematic and high priority issues were rarely disseminated to policymakers. So we're producing, but in terms of the uptake, there has been very few researchers. Also, we've done a study in 12 countries in the region, and this is published as well. And we surveyed health system researchers, and we found, in fact, that very few of them produce policy brief. They disseminate messages, they work with media, they interact with policymakers and stakeholders, and they involve them in the research. So we've also seen that also at the supply side we have a problem, and at the demand side we have also a challenge. So that's why in my university there was a strategic decision that they have taken, that they wanted to actually bring more academia into the policymaking process and the policy policy-making table. So we were able actually to get funds to create the centers called Center for Systematic Reviews of Health Policy and System Research. So this is the first of its kind in the Eastern Mediterranean region, and this is really joint collaboration between two faculties, and we get seed funding from the Alliance for Health Policy and System Research. So we do priority setting. We only produce systematic reviews on priorities, and those priorities need to be voiced by policymakers and stakeholder organizations. We do evidence synthesis. Now we're doing rapid reviews and rapid response, and we do capacity building at different level. We have also produced, we've produced, for example, many of those systematic reviews that were produced and published were basically a review question that was asked by policymakers. Can you tell me how I can address drug counterfeiting in my country? What would be the intervention that I have to do? What is the, how we can work with media to better impact policy? We've actually produced recently a Spark tool that will help identify and prioritize review questions for systematic reviews in health policy and system research. This was actually published a few weeks ago. So this is in terms of knowledge translation, we have a research production, we have policy making process. This is a little bit interlinked, so we created something called Knowledge Translation Platform, which is really an entity that links research to policy, so we can really try to provide evidence to policy on the priorities. There's another center which has now become a WHO collaborating center for evidence-informed policy called K2P. I'm the director of that center. So this is a center that's only specialized on knowledge translation. So we only do, this is modeled after the Health Forum, and we got seed funding from IDRC to do this work. And what K2P does is, in fact, we start by the priorities. We produce products. I'm going to show you we have 6 products, all of them in the public domain, all in the websites. And we convene policy dialogue. We do national dialogue or regional dialogue on priority problem. And we do evidence-based advocacy. And we do also policy tracing research. We try to see when and how and if research evidence was used in policy and why not, and what we can do to improve. We have 6 products. I'm not going to go into the feature of each one of those, but each product has its unique feature. So in policy brief, for example, we explicitly mention the problem, the cause of the problem, the size of the problem, and the underlying causes. We go into options, and we analyze options in terms of benefits, harms, risk, cost effectiveness, stakeholder reaction, and we do implementation consideration analysis. And this will be more of a jumping off point for national dialogue. To anyone coming to the national dialogue, they have to read this, which is written in very simple lay language, and then we actually convene dialogue, and we make sure that people are using evidence when they are deliberating about options and making decisions. We have a product only for media. We've done a study that we published in +1, and we showed that, in fact, media is ill-informed when it comes about talking about public health and when informing or shaping public opinion. So we show by evidence that the little evidence that they use when they actually use they write emotional stories that attract audience and readers, but not necessarily is based on evidence. So we are promoting something called evidence-informed health reporting. And we have rapid response. We have something called 3, 10, 30. So if sometimes the minister say, okay, I want something in 3 days, what can you do for me? Or 10 days or 30 days. And each of those 3, 10, 30 has the different features of how to do that and how we do it. So again, so our post center, Spark and K2P, this is this specializes in evidence synthesis, this specializes in knowledge translation, and the impact is to actually influence policy. We publish our framework, so we call it impact-oriented approach. We usually start by the impact we would like to achieve. So basically, what are the things that you want to tackle? How to actually minimize medical error in hospitals. So we start to say, okay, are we trying to change a law or not? We've done something on alcohol policy when it comes to youth, because we have high drinking levels among youth in the region. So we started to see, okay, shall we start by actually looking at impacting policies or laws or existing laws, or is it really about education and awareness and all this? So we always start by the impact, and we actually do backward mapping to see what are the things that we need to do at different levels. Basically, we want to make sure we want to answer something that policymakers want or need or require. We do evidence synthesis, rapid reviews, systematic reviews. We do knowledge translation. and we actually convene and do dialogue and advocacy and media engagement to make an impact. Now, this is not straightforward. I'm not saying that if you start here, automatically come here, but we're learning. So this is something that is really quite iterative in terms of this process. So in terms of the approach that we have done, and I'll give you, for example, in Lebanon, as you know, since 2011, we have been really, challenged by the constant influx of refugees to the country. So this is a country of 4 million. Now we have 1.8 million refugees. So more than 35% increase in the population in just a matter of 2-3 years. So there was really a major challenge. And the major challenge was we started to see communicable diseases happening, et cetera, et cetera. So we have actually worked, and we've done a priority setting exercise, and to identify what can we do. I mean, it took the government a few years to understand what they have to do. So we've done a priority setting. We get all the stakeholders, international organizations around the table to identify what is the question that we need to work on. And then we have realized at that time that the problem was not money. There was a lot of money pouring to the country to deal with the refugee. The problem was there was a poor coordination among government, humanitarian aids, UN institutions, et cetera, et cetera. There was no actually proper coordination model. So we produced 2 systematic reviews on this. We actually produced a briefing note about how to promote access to basic healthcare services to refugees in Lebanon. And then we actually did a policy dialogue. We brought all the international stakeholders, the national stakeholders, the governments, all the governments were around the table using the briefing note in order to actually inform decision. And this was the basis of actually now having a package in primary care center purely to refugees. There was a lot of things that happened as a result of some of the work that we have already informed. We actually, everything we do, we use the Chatham House rule. So we put everything there in a dialogue summary without associating any statement to any name. We do personalized debriefing. And of course, as part of impact, we were able to actually strengthen the Ministry of Health approach. Now we have a consolidated health information system on refugees. There was now a refugee health coordinator recruited as a result of this work. And now there is actually a plan that has been developed to deal with that. So what we do is that we actually, this is about medical error. So we've used the same approach, and we started by a priority. We've done a scoping, we've produced policy brief, we brought people in the dialogue, we produced dialogue summary, and we go to media. We try to work with media in a very strategic way because media could actually influence and inform a policy. We've done capacity building to all journalists of how to actually use evidence. Sometimes, we receive calls at 12 midnight. I have something early in the morning. Can you give me some evidence just to actually, so we try, with not all the time we're responsive, but we're also learning. Same thing for mental health. We've done the same model for mental health. So now we have a mental health program in primary care centers. We were able to integrate mental health in primary care as a result of this model of what we have been able to do. We've done also on regional. We've done on child protection in Iraq. So we're able also to do a policy brief, and we have done actually, there was a ministerial decision from the Prime Minister in Iraq related to child protection law. Now we're actually revising child protection laws even in Lebanon because we do some social policy work. So the missing link, I'm going to end in terms of this. What we have learned is that, sometimes you don't have a lot of time to do systematic reviews and primary studies to actually cater to the needs of the policymakers. And one of the things that we've learned that policymakers do decision regardless whether they're going to give them the evidence today or not. So meaning they will not wait for you or for us to actually give the evidence. The question is really, what do we do? So we scaled up the operation to rapid response. So we have a rapid response program now and now we are actually we're contributing to the Lancet Commission. So now Spark and KTB has been commissioned by the Lancet to actually support the Commission when it comes to there's a Lancet International Lancet Commission on Syria, and actually we've actually just produced something on the scoping review that we have done on the related to health workers. As simple as that. I'll summarize this in this. 2 years ago, I received a call from the Minister of Health through the ministry, and he asked me for a meeting. I came with my team and as a director of the center, and he told me, shall we implement the salt fluoridation law in Lebanon? He's a politician. He's not a public. He only wanted, because there was a lot of debate in the newspaper about it. He said, shall we implement it or not? And I want a quick answer. He gave us 10 days. So we were able to produce a product in 10 days. And we actually showed that this was harmful and it will affect the health of the population if they go and implement the salt fluoridation law for many reasons. We showed him the evidence for that. And actually now this law was stopped. So they didn't implement it as a result of this type of work. So again, one of the things now we are also Spark is, I don't know if you know about GESI. So now there is something called Global Evidence Synthesis Initiative. So this is a consortium of different organizations, including Cochrane and other institutions. And Spark is actually the secretariat for the GESI initiative. We have now a global network of 37 evidence synthesis centers from 24 low-middle income countries to actually work and to ensure much more interdisciplinarity in producing research with a focus on SDG. I'm not going to go into the detail, but you know how we get people from education, from health, from mainstream economy, agriculture, etc., all work together in order to actually shape or influence the SDG goals. Lessons learned quickly. It's really, you know, if we want to influence policy, we need to always keep and providing evidence, timely evidence, and actually policy-relevant evidence. We need to make sure that we focus on interdisciplinary research. We bring different disciplines together. You know, if there is no demand, create the demand. It's not all the time you will be called for, or you know, the university will say, okay, please give us evidence on this particular issue. We try to build capacity for policymakers about how to actually start asking the right questions and looking for the right evidence for that. Engaging them, we engage them from priority setting up till impact. So that engagement is not easy. There's a lot of sometimes conflict of interest. We try to make sure that we keep neutral, objective, so this will not affect how we are actually providing evidence. Understanding the political system is very important. So we do work in different countries now in the Middle East, and I tell you, there is no copy-paste solution to problem, although it's the same problem. But the political factors, the political context, the political economy of things, we need to actually understand better in order to actually cater to the needs. We call it the three rights. We need to have the three rights in place: the right priorities, right timing, and right framing. This is the knowledge translation, as I said, is very important that we need to work on, and engaging civil society groups. So now we work with civil society groups. We have advocacy framework in order to actually influence and provide timely response to policymakers. So my last slide here is that I believe that impact is the driving force for the entire process. So what we're learning, how we can measure it. Because there is no straightforward of saying that you do this and you end up with that. There's a lot of other factors that come to play. So now we're working on the measurement, and we'll have actually in London now in December 13 and 14, TDR will be funding a meeting that we'll have about how we can go about institutionalization, how to institutionalize the use of evidence in policymaking institutions in low-middle income countries, and how we measure impact. Thank you so much.
Thank you, Fadi. That was a really impressive range of activities that your center's getting up to, and I think underlying that must be some really strong relationships with policymakers. So maybe that's something that will come out in questions a little bit. Again, we have time for 3 questions, keeping them quite brief. 1, 2, 3.
Hi. Yeah, thank you very much for your presentation. Very insightful. My name is Abdurrahman. I'm one of the student master of public policy here. My question is, because I come from EMR country, how do you sometimes not go with the tide of the policymakers and produce a research in their target or in their aim, and actually persuade them to change their priority, rather than actually just produce a simple research? That's my question to you, in a highly political situation.
Yeah, thank you. Great, thank you. Our second question.
Hello, I'm Marion Lynch. I'm from the NHS in England, and it resonates exactly with what you're saying. Have you had any times when your politicians have misinterpreted the evidence on purpose and gone the other way?
Yep, thank you. And our third question.
Thank you very much for your presentation. I'm doing an MSc in Evidence-Based Social Intervention and Policy Evaluation, so this was really relevant to me. My question is, how do you deal with competing pressures in the policy environment? For example, economic or social pressures. giving an example of tobacco, where we have evidence of how it is bad on health, but because of economic reasons, some governments are not enacting policies to ban it. Thank you.
Great. So 3 great questions all about the politics of evidence and evidence use.
Yeah. So I think my quick answer is that we're learning, and we're learning the hard way. And yes, throughout the questions that we learned, that how can we keep engaging with policymakers and build that trust, but stay neutral and objective. And I tell you, we had a lot of attempts. It was not a success because we felt that policymakers were actually trying to capture us and use us in a very opportunistic way to actually more promote some of their agendas. And I tell you, at some point, we got to a point where actually we agree to disagree. So basically, and I tell you, I have a lot of examples. We don't have time to that, but I tell you that there are some topics that we intentionally opted out from because and now we're very, very clear. Every time we work with government, we have MOUs with the parliaments and with the ministry, and we put those conditions that at any time we feel that really there is some type of capturing. It's not written that way, but in terms of really this, so it will not affect the neutrality and the objectivity. So our aim is actually to be a trusted source of evidence, as simple as that. So what we say, we tell politicians, we're not here to change political regimes. We're here actually to help you make much more informed decision. We know that there are other political factors that come to play, but what we want you to actually make sure that there is evidence that is used as one input into the policymaking process. It's not easy, I tell you, and that's why some they feel that this might not serve their interests. So I'm not generalizing, but I've seen I work with a lot of policymakers and politicians, and some of them they have self-interested behavior. They use the opportunistic behavior sometimes, and if the evidence, and they like to actually be much more opportunistic in terms of which evidence they use and which evidence they don't use. So they are much more selective. So that's why in our products, it's very clear. One of the criteria, we are very transparent of what is really out there or not. So meaning, if we hear from the policymaker that they want an option like this, and if we couldn't find any systematic reviews or any high quality study that meets a certain criteria, we're upfront about it. We say, look, this is the lay of the land. We have a major gaps here, and this is so we try to actually make sure that to keep that distance, so arm's length, but yet working with them. But at the same time, we never use the confrontational approach. We always use the engaging approach. Because honestly, it's so easy to criticize government, but this will not tell us anything and will not get us anywhere. I think we need to work with government. We need to accept the reality, because that's the politics of making decisions. But we use the approach is not, you're doing this, but we use the approach, you're doing this, and it makes a big difference when you come to the policymaking table to say you're not challenging them, but you're actually trying to say that you understand their world, but there's something that they can do better. And that's why we use the great what you're doing, but we don't say the but. But again, we're learning. So I don't know, I don't know if this is a bit closer to the second questions about the politics. But the interpretation that my answer, I don't have a specific example to this, but we had examples with media misinterpreting the evidence. Although we actually put it in a very simple lay language format, and sometimes, unfortunately, they use it in a very and I'll tell you why, because many of the media outlets that we have in our region, that they are owned by politicians. So there is also a vested interest of actually using and manipulating some of those type of evidence, and I don't think sometimes intentionally and sometimes not intentionally, but intentionally because there is a political agenda, but unintentionally sometimes because they have poor capacity to understand evidence. But what I would say about the interpretation is that we really need, and we're still learning, how we can write in a very simple, targeted, user-friendly way to politicians and policymakers, and to avoid the misinterpretation piece. I think this is something that also we're still learning in terms of this. The third question, if you remind me, is about evaluation.
On competing pressures.
Yes, so the competing pressure is, I think this is one of the things, and for example, I will mention about the tobacco law that we had in Lebanon that failed at the level of implementation, that there was a lot of argument that, you know, the economic piece, how can we go with this, but there was a strong advocacy coalition that actually helped create a law, but it failed at the level of implementation for different factors. So what we do now, is that I think this is a very important piece. That's why I say the copy-paste solution to problem from one country to another does not work, because the political economy of health is different across among countries. So the question here is that when we go to a certain country to look at a particular problem, this means that we need to understand what all the factors that come to play, the social, the economic, the health, and the other factors, in order to make sure that we provide a context-sensitive type of options or solution that could work in a particular context. But I tell you, we've done a work on the interaction between pharma companies and physicians. I tell you, we were really, you cannot imagine how much criticism we get from pharmaceutical groups, because we have been really trying to, and we said, you know, this country is paying too much on drugs, on pharmaceutical drugs, because there's an unethical relationship between pharma companies and physicians, and we showed it by evidence. But, you know, there are other factors. Physician group didn't even like it because there was benefit coming out of it. Again, I'm not generalizing, but this is in my country. So there are other factors sometimes come to play, but I think we speak truth to power sometimes. When you have strong evidence, I think you go about, out there with it. But my answer to you is that understanding the context is very important in order to actually try to provide a solution that could work. It might not be a perfect solution, but you need to have a workable solution that you can use to scale up in order to achieve impact.
Great. Fadi, thank you very much.
Thanks.
As our next speaker is coming up, I'd just note that as the more time-conscious among you might have noticed, we're running 10 or 15 minutes late. So we're going to end the session closer to 6:45 than 6:30. If you do have to leave right at 6:30, please feel free to do so quietly. Our next speaker is Tomás Pantoja Calderón, who is a specialist and surgeon at PUC Chile. He also works on medicine from a social science angle as well as from a purely medical angle. And he's staying on this topic of evidence use, but now shifting back to Latin America. So, Tomás, thank you.
Thank you. Well, my presentation is very related to what Fadi has just presented, because we have been working during the last, 7 years in the same area, but maybe have a little bit different flavor in terms of the use of evidence at the health system level, and I will present a specific experience that in which I have contributed. I am presenting this on behalf of the people, doing the hard work at the Ministry of Health. And these are the guys that are doing this in a day-to-day basis. And the challenge being addressed by this initiative could be seen in different ways. One way you can see this is a divide between two very different, worldviews. This is just to illustrate, sorry if I am going too fast. Then this to illustrate this issue in some way, maybe it's simplistic, but it's just to see some ways where are within each other in terms of the policymaker and researchers. Another way you can understand this is related to the format in which research is presented to policymakers. I am in my university also as systematic reviewers, and we tend to accumulate a lot of paper and then go with that specific piece of evidence to the decision makers, and you find this. And also the challenge could be framed in relation to the role of evidence in the policymaking process, contrasting these idealized views with the real world of decision making. then the challenge can be seen, or seems to be a number of ingredients. It's not a single challenge. And especially in terms of knowledge translation, this last point could be more specific, and we can talk about these different areas because of which research evidence is not used in decision making. Then the Chilean response, and not only the Chilean response, this has been an initiative called EVIPNet, that is a WHO-sponsored initiative that promotes the regular use of research evidence in policy making, has been implemented in a number of countries across the world. But in Chile, it was formally established after 7 or 8 years, was launched in the Americas, and was just implemented at the Ministry of Health by the end of 2014. And conceptually, EVIPNet is a kind of knowledge translation platform. Fadi has already mentioned this concept that promotes this specific partnership with, among policymakers, researchers, and civil society organizations at the country level, and propose a structure, a process, and product. In the case of Chile, in contrast to what Fadi has mentioned before, EVIPNet is located at the Ministry of Health as part of the formal structure, what allows in some way connection with decision makers and with other stakeholders outside the minister. Like here is mentioned the civil society, regional government, research centers, other healthcare providers, and university. And in this case, the work has been organized since 2014 around a specific strategic objective and the initiative. This is the matrix in which those objectives and initiative has been organized. And my intention now is quickly walk through the initiative to give you some idea of the work done in the country. Let us start for something that Fadi already mentioned that I will revisit at the end of this presentation in terms of the importance that rapid response service can in this kind of knowledge translation platform. These services try to address a common situation where policymakers need to inform a decision as soon as possible. For this, rapid response service produce rapid evidence synthesis in less than 20 working days, systematically reviewing the published evidence on a specific topic, making a sort of trade-off between the opportunity and the depth of the search for evidence. The process for producing this starts with a question posed by the decision maker who chooses a timeline for the synthesis. As Fadi mentioned, sometimes could be 3 days, sometimes could be 10 days. Then the EVIPNet team find and apply systematic reviews to deliver an evidence-informed answer, which can be also shared with the civil society. This is the format, and sorry because it's in Spanish, but this is the format of the response taken from previous development in the support project that was another project funded by the European Union. But it's a format we have used for this kind of product. And here are some examples like the evidence about food labeling, and the use of telemedicine for the treatment of a stroke patient. As you can see, the range of topic is very broad in terms that it depends mainly on the needs of different decision makers. So far, the team has produced about 40 rapid response based mainly on systematic review. There is no primary studies, mainly there are systematic review that are collected and put together in the format that I previously showed you. And then in the matrix, rapid response mainly address the objective 1 and 3, that is to promote the use of best available evidence and to promote the collaboration between policymakers, in this case, and researchers, because they put in contact policymaker and the research team at the Ministry of Health. Regarding the second initiative, that is the website, it looks like this. And here I have to mention some of the constraints about the website, because as Fadi mentioned, in the initiative of Spark, they have the product freely available. Here, there has still been some difficulties because the minister found complicated to get the website publicly available because people can contrast what the evidence said in a specific product and then what was the decision. Then this is the kind of constraint that you have in terms of having a specific unit within the Minister of Health. And we are still struggling with the issue about, okay, how we can make this publicly available. And in terms of the objective, the website is addressing objective 1 and 2. Then there has been a number of capacity building workshops, and these are training activities focused on promoting the use of research evidence in health policy making process and in the preparation of evidence-free for policy. That will be the next initiative or product that I will be talking about. They are commonly half day long, and 4 of them has been carried out during the last year. The audience usually came from the different departments of the Ministry of Health and academic organizations. Then workshop are mainly addressing this second objective. Now, the evidence-free for policy, that is some that Fadi has already mentioned. Then starting from a policy issue or problem, the evidence-free for policy try to identify evidence to clarify the problem, to frame the relevant option to address the problem, and to identify implementation considerations related to those options. Following a specific guidance, this task has been delegated to a network of public health department schools in Chile. This work has been supported by PAHO, that is the Chilean country office. PAHO is a regional office for WHO in the Americas and has been funded by the specific Chilean country office. And here are some of the examples that has been produced so far. The hospital interventions to manage freight in the elderly patient and price regulation mechanism for medicines. And again, the evidence-free are addressing objective 1 and 3. And finally, something that Fadi has already mentioned, that is the policy dialogue, or the discussion of a policy issue based on the existing evidence in the form of evidence-free for policy or a rapid evidence synthesis. And the relevant stakeholders discuss about this specific issue. And these are some of the ones that has been carried out so far. Then the dialogue focus on objective 2 and 3. And my 2 last slides are related to some lessons learned that mirror what Fadi said, but in some way are different or has a different taste. The place where EVIPNet is located, or the knowledge translation platform is located, is important. In our case, being close to decision-making spaces has been useful, but challenging in terms of responding to a high volume of requirements from policymakers. Although most of the time is spent in the rapid response service, it is good to have a variety of activities and products in order to address different objectives. The rapid response service has been very useful for validating the initiative within the Minister of Health, and we think that it's a good starting point for the implementation of this kind of work on other places. And taking into account the amount of resources that are needed to produce all that kind of product, it's desirable to expand the network capacity through the collaboration with other institutions such as academic institutions. In our case, the Department of Public Health of different universities. And some of the future challenges that we have identified, the main product of the rapid response service are rapid evidence synthesis based on available systematic reviews. There are a number of guidance out there for rapid evidence product, but they are not exactly what EVIPNet is producing. And then the team is preparing a methodological handbook in terms of sharing the methodology that we are using and maybe discuss with other teams that are working in this area. adding other initiative is something that we are looking for, but always is the issue about the resources, the rapid and living systematic review, living in the terms that they are being modified when new evidence is appearing, or citizen panels is something that we are exploring. As Fadi mentioned, one of the main issues for this kind of initiative is how to monitor and evaluate the initiative in terms of the impact that you are achieving. And the sustainability is the same issue that has been mentioned before, especially after general election that we have next month. We think that currently the initiative, together with other initiatives in the Ministry of Health that are focused on the use of evidence, will survive because they are not a high-level issues, but it's always something that we have to consider. And then you can find more specific information if you want in that recent publication in a regional journal. Thank you.
Thank you, Tomas. It's really interesting to see this slightly different model of evidence use, which I think provided a really nice contrast. So we again have time for 3 questions from the audience. 1. Okay. Go ahead.
Thank you for your presentation. So both you and Fadi talked about this rapid response approach, and I'm just wondering, what are the major deficits of this approach that exist in terms of evidence quality that differentiate it from a sort of longer, more intense approach that looks at developing a systematic review over a year? What are some of the major barriers you're facing?
Great. Any other questions from the floor? So I might just abuse my moderator's privilege in that case. So I would be really curious to hear your thoughts about where you're drawing your evidence from. Obviously, there are a lot of studies are conducted from outside Chile or Latin America. And how do you think about translating evidence of policy's effectiveness in other contexts to your own? Has anyone been inspired? Yeah, Mike.
So taking my privilege of being able to ask a question as well. I'm interested in the level of resources that you feel are needed. In truly lower income countries, how much do you need to get going in terms of maybe people? I think they're the critical expense, I would guess, skills and people.
Yeah. So for those people who are watching on the live stream, that question was about the level of resources that is necessary to get something like this going.
Yeah, well, the first one is about the difference between a formal or full systematic review and the rapid response. That in that case, there are different, kind of product. The one that we produce, but any other kind of rapid reviews require to take shortcuts. And I think that the shortcuts normally are done at the level of the search for evidence, the comprehensiveness of the search. Then you have to make decisions about that. Then you can. If you have a structured process, then you can see, okay, we search for evidence in these sources, and if we have more time or more resources, in our case, time, because the difference between a response in 1 day, 3 days, or 10 days is related to the number of sources that we search for evidence. And the second one, the big one, is about the quality assessment in that case, of the reviews that you have. If you have a shorter time, you are not able to assess the quality of the evidence in terms of the specific process. For instance, some of you will be familiar with the grading approach. Then these are the 2 main shortcuts in terms of the time that you need for that. But there is no a specific methodology agreed for all the groups that are working on this regarding this specific issue. There are a number of publications about, okay, if you could for this site, you will obtain this and this. But I think that we are, exploring what is the best ways to go ahead with this.
My question was about the role of context
the local,
and external validity.
I think that you always struggle with this issue about how to inform decision with on one side, global evidence from systematic review, that is the main issue in the rapid response, and then how to integrate local evidence. I think that if you have a specific procedure in which, okay, the evidence about, for instance, in our case, we structure the question about, okay, the problem, the option, and the implementation consideration. I think that in terms of framing of the problem is informed mostly by local evidence. Then the assessment of the impact of the specific option that you are considering is mainly informed by global evidence. And then the implementation consideration in terms of the barriers that you can find for each option, you inform that for local evidence, and then the strategies to address those barriers again in the global evidence. But you can mix that, and you can use in a flexible way the different kind, but have to be systematic and transparent, because this could be contested by other people. And in terms of the level of resources, I think that we struggle with this to put this in the Ministry of Health for 5 to 7 years with 2 or 3 different governments. And at the end, in 2014, we were able to generate a specific position for one person. One person is doing all this work with 2 other persons. One is a, political advisor in terms of protect this guy for doing this. And the other one is some kind of technical advisor. That is my role from the university to, to provide with the technical guidance relating to that and to go ahead with that. I think that this is the minimum requirement. Hopefully we have more people working on this, but in this case, we have that. This is what we have, and we have been, because if we waited for more people, really the minister is not able to provide more resource for this specific initiative.
Great. Tomás, thank you very much. So that wraps it up. The next in these series of global health systems workshops will be on December 6th, where Richard Littleford will be speaking at Green Templeton College on slum health issues. So thank you all for coming out. Thank you for joining us via the live stream. The speakers will be here for a few minutes if you have specific questions for them, but otherwise, have a good evening.